we doing back there? Can we hear the cats from the foyer? Okay, this is pretty much everyone. Okay, so y'all have to tell Dr. Woodham that I am keeping on time even though she is not here. We're gonna get started because we'll keep it as close to time as we can. So our next talk is again by Dr. Tuuli, and you know his whole bio from yesterday. He's gonna talk to us about intrauterine postpartum hemorrhage and control devices. So I really did have to tell y'all yesterday I had a flashback while Dr. Tuuli was talking because I'm really old, and Dr. Luella Klein was fixated on anemia, and Dr. Tuuli didn't know that. And I checked this out with Dr. Lindsay and Dr. Karak, and so I felt her in the room with us yesterday. It was so fitting that that was the topic. And although Dr. Tuuli needs no more introduction, I have one little addition to his bio, and I know I'm gonna break some hearts in this room. Dr. Tuuli was Dr. Span's favorite. Without further ado, here we go. Welcome, Dr.
Tuuli. All right, thank you so much. It's my pleasure again to speak on the second part of my lecture. And this has been a great conference, really, of all the ACOG and OBGyn Society conferences I've attended. This is really the best that I've ever attended. So today, I'll continue the theme on blood. So yesterday, we talked about ensuring that it is formed in adequate quantities by adequately repleting iron in those who are iron deficient. And we know that postpartum hemorrhage is a risk factor, anemia is a risk factor for postpartum hemorrhage. There are emerging technology and data on intrauterine devices. So I thought I should use this opportunity to review some of those because I'm sure you are getting calls at your hospitals about this new device that some of you may be using as well. So again, staying at the intersection between clinical practice and research, I would like for us to review some of the data and ongoing studies around this, so at least we have the evidence in perspective as we work on our practice. So we reviewed this yesterday, and for the purposes of this presentation, at that time, the company that manufactured Jada was a startup called Alidia. And I was one of the investigators that conducted a trial that led to FDA approval. So they funded that study. And we are conducting the first RCT of the Jada system in Ghana. And it's an NIH-funded study, but we are getting the devices donated by now OBGyn, which is an offshoot of Merck. So by the end of this presentation, I want us to have reviewed the role of intrauterine devices in postpartum hemorrhage management, understand the state of the evidence, and then also think through some of the ongoing studies and the data we can expect to have in the coming years. So postpartum hemorrhage, when I was a resident, we defined it by whether you had a vaginal delivery or a C-section. And that just didn't sit well with me because the body does not care whether you had a C-section, you did a C-section or you delivered vaginally. The body will respond to a volume of blood loss. Although we know that the estimated blood loss is often lower of vaginal deliveries, the more contemporary definition that has a single value or a response to hypovolemia as the definition of anemia, it sounds better with me. So contemporarily, postpartum hemorrhage will be defined as the loss of a liter of blood after delivery, irrespective of the route, or any amount of blood loss which results in signs and symptoms of hypovolemia. It's a big deal. So postpartum hemorrhage affects 5 to 10% of deliveries, depending on how you define it and the population. And it's the leading cause of maternal mortality worldwide. Globally, about 27% of maternal deaths are due to postpartum hemorrhage. 16% of those occur in developed countries. And for the purposes of this presentation, postpartum hemorrhage is the leading cause of maternal mortality in Georgia, accounting for 16% of those deaths. And it's not all about mortality, it's even more important about morbidity, because morbidity tends to occur more often than mortality, and if we can reduce morbidity, we have a better chance of reducing mortality. And postpartum hemorrhage is the leading cause of maternal morbidity in the US. You know, we all know this for the sake of the residents, multiple causes of hemorrhage, but of all of those, uterine atony, where the uterus fails to contract adequately after delivery, is by far the leading cause. What are the risk factors for postpartum hemorrhage? There are many, including prolonged labor, uterine overdistension, some medications we may use, and C-section itself is a risk factor for postpartum hemorrhage. But although patients with these risk factors are at a higher risk for hemorrhage compared to those who do not have them, those factors alone do not accurately predict who will have a postpartum hemorrhage. We all have stories of that patient who had no risk factor, pregnancy for the first time, everything went well, and they delivered and they started hosing. And then also that patient who is a grand multip, who is pregnant with twins, and we're already typed and crossed, and we never use that blood. So the bottom line is that we cannot accurately predict, and so the mantra is to be prepared at all deliveries. The beauty about obstetrics is that, complications can arise suddenly, and we have to be prepared to do those, to take care of them. Of course, for those who have, unique risk factors such as, invasive placenta spectrum, planning that delivery and potentially sending them to a center where they specialize in doing those would be prudent. Preventive measures, we all do active management of the third stage of labor, and universal management, including uterotonics and uterine massage, reduce the risk of postpartum hemorrhage by about 60%. But that means we still have that third to deal with. And when those things happen, we have a range of options, ranging from medical treatment, where we give more uterotonics, and then mechanical therapy, and I'm sure all of us have our techniques of trying to do that. We are lucky to have uterine artery embolization in many centers, and then when all fails, surgery, where we laparotomy if they had a vaginal delivery, or if at C-section, we can do vascular ligation, although I bet that especially with those of us who came across along later, the scale for ligating, the internal iliac artery, especially in the setting of pregnancy, is, truly a dwindling skill set. That means most of us will proceed to C-section when we cannot control bleeding. This talk is going to focus more on the mechanical options and particularly on the devices. All right, we are all familiar with intrauterine balloon tamponade. There are many options. The Bagri balloon is probably the most commonly used. And it was invented by a guy called Johannes Bagri. I'm friends with him on LinkedIn, actually. So as we know, this device consists of, the balloon, which is inflatable, the shank, a port where we put fluid in to keep it stabilized. And then, we put in the uterus, inflate it up, and it works by applying tamponade to the uterine wall. How effective is this thing? So you will hear me repeat this a few times as we go along. It is true to say that all bleeding stops. Unfortunately, the patient may die, but all bleeding stops, which means we have to be really careful when we evaluate systems for stopping bleeding. Just because you use that device and the bleeding stopped doesn't necessarily mean that it is that device which stopped the bleeding. So when this review was done now 3 years ago, they reviewed 91 studies, including nearly 5,000 patients, on the effectiveness of the Bagri balloon. Most of them were case series. So meaning we applied the Bagri balloon to 50 patients, and we said it stopped the bleeding in 80%. But remember, all bleeding stops at some point. There are a few randomized trials, and so we'll review what those studies told us about the Bagri. And of course, we all have our anecdotal stories about how we just put that Bagri in and the bleeding stopped, or we put it in and it didn't stop, and we could not even get to put it in as an intervention. So overall, those data will suggest that the intrauterine tamponade devices control bleeding in about 86% of cases, and with an adverse event rate, whether it is a laceration, a perforation, and all of those, are around 6%. But the devil is always in the details. So 2 of those were straightforward randomized control trials where they randomized patients to using the Bagri balloon or not using the Bagri balloon. And there was no significant, statistically significant reduction, although the data pointed towards that direction. There were 2 non-randomized studies which showed a significant reduction, almost a 70% reduction in bleeding compared to patients who did not use it. And then there was also 1 cluster randomized trial, so where they said, from now on, this group of hospitals have a policy of using the Bagri balloon as a mechanical device, and you don't use it. And then they found that, comparing those 2, there was a statistically significant reduction in the use of invasive procedures. So let me take us globally a little bit. Unfortunately, even the Bagri balloon, which costs, I don't know, $50, $100, is not available in some places around the world. And people are smart. So they did some contraptions together. So this is a device that is used a lot in Africa. So it's take a condom, attach it to a Foley catheter, put it in the uterus, inflate it. You have your intrauterine tamponade device. Now, let's see, though, when they tested it, what did they find? So this study from 2017 was an RCT of 116 patients, conducted in 7 hospitals in Mali and Benin, where they used the condom catheter plus misoprostol or just misoprostol alone. They found that there was a non-significant, not decrease, but increase in the rate of invasive procedures or maternal death, 16% versus 7%. So it caused a lot of uproar. What is this? This was not really a good study. And then another one followed in 2019, published in 2019, which was a stepwise study, which is where you start with all facilities not using any device. So you collect the baseline data, and then you implement it on a rolling basis, and you compare outcomes in institutions before to after they were using the system. And what did they find here? They found a statistically significant increase in postpartum hemorrhage-related morbidity. So the question in everybody's face is, why? I have a few guesses. So one of them, I think, is that while you are busy putting this contraption together, you are not doing the basic things that you need to do to stop the bleeding. And as somebody who practices in a low-resource setting, it's not like here where there's the attending and the fellow and the resident and the medical student. Essentially, often is the one person, maybe a midwife, who is the one in that delivery. And so when complications happen and you are paying your attention to tying this condom to a Foley catheter, you are not doing the ABCs that are important to stop bleeding. So the WHO came up with a statement which said, after a thorough review of the benefits and risks of tamponade devices, especially the homemade ones like the condom catheter, that they should not be used except in places where you can proceed to surgical intervention if those failed. This is still controversial. Some people still think something is better than nothing. But we should remember that when we change practice or when we have policy, it isn't that we do everything else and then add this thing. Sometimes by adding a new intervention, we actually subtract from what we are already doing, whether it's time or attention or resources, as the case may be. So what's the summary of the data on intrauterine balloon tamponade? The data are mixed, right? So we all have our stories, and they account for something. Some people are better at putting this thing in and in the right patient at the right time. There's some data on who is likely to benefit and who will not. But non-randomized trials suggest benefit. Randomized trials are still mixed, especially the improvised ones. Those really need scrutiny. this is critical. It does not appear to me that the uterine balloon tamponade, whatever system it is the most physiologic. So we have uterine atony, the uterus is not contracting. What does nature do? Nature will tend to cause the uterus to contract and stop the bleeding. What does the tamponade do? It actually inflates the uterus a little bit. And sometimes when it's difficult to figure out the answer, I think asking the question, what would nature do, is sometimes often the better way to approach it. We also know some limitations of the Barré balloon. For example, you may not be able to put it in. We need to put it in for a long time, and then we debate, do they have to stay on labor and delivery, or they need to stay, they can go to postpartum. And then, if you don't remember to put the Foley catheter in, that bladder will balloon and bad things will happen. All right, then comes another system, which is the vacuum-induced system. Really neat story. So the story goes that a group of students at Caltech were given a class project, and they said, this is what postpartum hemorrhage is, this is the main cause. If we were to develop the ideal system to control bleeding, what would you develop? This was a group of engineering students, and they came up with what is now the JADA system. So what is the JADA system? It consists of this soft silicone elliptical region. It's connected to the shaft. There's that bulb, which is inflatable with saline to keep it in. And instead of putting fluid in for tamponade, you connect it to the wall suction. It creates a vacuum, and the uterus collapses under its own weight, mimicking, I will say in many ways, what nature does. So this is the JADA system in place with the balloon inflated, connected to the suction, and I hope this video works. So caution before we go to the video, it is from OBGyn's website, so you will hear it presented as such, but I don't have an animated video of my own, and I will give qualifiers where it may not be the case. So let's spend a couple of minutes.
The JADA system is a treatment for postpartum hemorrhage and abnormal postpartum uterine bleeding. JADA uses gentle vacuum to induce the normal contraction of a postpartum uterus and achieve physiological control of postpartum bleeding. In a clinical trial, JADA was proven effective in stopping hemorrhage in 3 minutes without the need for further treatment. JADA is made of soft silicone and is exceptionally easy to use. The intrauterine loop evacuates blood from the uterus. The cervical seal holds a vacuum within the uterus, and a connector at the end of the tube attaches JADA to a regulated vacuum source. JADA is placed transvaginally by gently guiding the intrauterine loop into the uterus. The cervical seal is placed at the external cervical os and filled with sterile fluid to create a vacuum seal. The vacuum source is set to a low level. Vacuum tubing is connected to JADA, initiating therapy. Evacuation of blood into the vacuum tubing and canister should follow. In the pivotal clinical study, uterine collapse was typically observed within 1 minute of vacuum initiation. Blood flow continued for a few minutes after uterine collapse. Once bleeding is controlled, JADA is left in place with vacuum applied for at least 1 hour and until the uterus is firm and the patient is stable. All fluid is removed from the cervical seal, and JADA is left in place with the vacuum disconnected for at least 30 minutes. Vacuum therapy can be reinitiated as needed. If bleeding remains controlled, JADA may be removed. The JADA system is a rapid, definitive, and physiologic approach.
All right, let's now dig into the data behind the video. So first, this device was tested in a feasibility study in Indonesia. We can have a long conversation about, why Indonesia and the ethics of that and so on. But it was first tested in 10 patients in Indonesia and was found to stop bleeding in all 10 within 2 minutes. And I think the rapidity of stopping bleeding is an important feature of any device because the amount of blood loss is the rate times time. So if you can stop bleeding quick, then less need to transfuse and so on and so forth. And then the first US study was what is called the PEARL study, and that's the acronym for that. And I was at the University of Indiana at the time and was one of the investigators that conducted this study. So it was a prospective, FDA-regulated, single-arm study at 15 hospitals across the country. The gestational age cutoff we used at that time was 34 weeks because it was thought for the first study, let's allow gestational age that we know the uterus will be large enough. Now it is used as far lower as 23 weeks or 24 weeks. And then at that time, we defined the estimated blood loss still based on whether they had a vaginal delivery or a C-section. This was the subsequent paper that came of that. So because this was a new system, it was quite difficult to do the study. And I'm still amazed that we talk to patients and they agree to be in a study like this. Yeah, this is this thing that doesn't really look friendly. And we don't know whether you will bleed or not, but when you bleed, can we put this thing inside your uterus? It's a miracle that people agree to do this. So we recruited and consented a large number of patients. Eventually, a small subset will develop postpartum hemorrhage. And so eventually we included 106 patients in the analysis. And this is the primary outcome, which was defined as bleeding stopped without the need for additional interventions, including surgery. By the way, blood transfusion and continual uterotonics, you could do that and it wasn't considered a failure. So the bleeding was stopped overall in about 96% of cases. And remember, it was a single-arm trial, so that was compared to the average in the data at that time, suggesting the benefit of the Barry balloon. And so based on that data, it appeared that the JADA system was quite effective in stopping bleeding. This is even more interesting that in nearly 70% of cases, bleeding was stopped within 3 minutes. And in another nearly 20% of cases, it was stopped within 4 to 5 minutes. So in about 90% of cases, your bleeding was stopped within 5 minutes, which, as we mentioned earlier, is useful in the context of postpartum hemorrhage. What about adverse events? There were no adverse events that were judged to be directly related to the JADA system, but 6 participants had adverse events. And what were they? Endometritis. And so you could argue whether postpartum hemorrhage itself is a risk factor, but putting a foreign body in the uterus is also a risk factor. So, and these were treated with antibiotics without any sequelae. In another case, there was extension of a vaginal laceration that was repaired, and then the device was placed and it was found to have opened up and it was sewn up again. So that's suggested reasonable safety. What about the experience of the physicians who placed this device? So, most of them had great experience of it. In the dark blue, they thought the instructions were clear, 84% of respondents. It was easy to insert, easy to remove, did not prohibit other therapies, and so the overall experience of physicians with this device was good. So following that, the FDA approved the JADA device for clinical use, and this is a post-marketing study, which then looked at how did the JADA perform in quote-unquote real-life, non-clinical trial study. So this included over 800 patients who had a JADA system across the country in 16 US medical centers, and they found that the success rate was around 90%. That's not unreasonable because in the study where it was strict and people were hyper-trained, it was higher. And when you put it in the real world, we come in different skill sets, but 90% still looks good. And importantly, adverse events potentially related to the device was quite low, was around 1%. So although this study was also not a controlled study, meaning there was no control group, the data were promising for the safety and efficacy of the JADA system. There's only been one comparative study of JADA compared to the intrauterine tamponade, the Barry system. This was published a few months ago in the Canadian Journal, and it is an observational study where a hospital system in New York, where they use the JADA sometimes and use the Barry balloon sometimes, In 114 patients, they compared the data between 2019 and 2021. And these were their main outcomes. They found that blood transfusion-related blood loss, the amount of blood lost, and blood transfusion-related outcomes, 4 or more units, which most of us would define as massive transfusion, or 2 or more units, was significantly lower in patients who use the JADA system versus those who use the Barry balloon. Other outcomes, such as hysterectomy, ICU admission, and so on, were not different, but it's 114 patients. However, there are some limitations of that comparative data. The first is that it's retrospective, and a provider made the clinical judgment to use the JADA in one patient and the Barry in another. And so the reason, the indication for use may be related to the outcome as well. So the study may be biased in that way. There's clear selection bias in the sample, because for patients who use the JADA system, it was used at a much lower estimated blood loss, about 870, while in those who use the Barry balloon, it was over 1.5 liters. So, just by that alone, you could expect to have better outcomes with the JADA system. The sample size, 114, sounds reasonable, but it's modest compared to all the things that we do. So the preliminary studies, the 800 sample size post-marketing study, and this comparative data set is promising for use of the JADA system for treatment of postpartum hemorrhage. I have to mention this before I go to new and ongoing trials on this system. So this was published in the Green a few, I think last year or so. But someone in Switzerland thought about an ingenious way of using the Barry balloon. So just following what we just said about physiology, that they did not want to expand the uterus, they wanted to constrict it. In this study, or in this use, they placed the Barry balloon under ultrasound guidance, placed a little bit of fluid to stabilize it, but instead of expanding the uterus, they then connected that system to vacuum, and it resulted in a collapse of the uterus. I thought that was really cool. I wish I had come up with it, but I did not. So what did they find when they analyzed the data? So just 44 patients, it's an ongoing cohort, so I hope we have more data later. But in the 44 patients, the overall success was 86%, and it controlled bleeding in about 2.5 hours, or they used it for about 2.5 hours. But the success rate was a learning curve. It was lower at the beginning, and it continued to improve, and by the end of the study, 2 years later, it was effective in about 100% of cases. So I think it's really cool, ingenious use of something we already have and we already use, and which is cheaper. But again, this is a study with our control group, and we hope that they do a larger study that compares it to something. I will imagine put the Barry balloon in each group, inflate one, and in one connect it to suction and see which one works better. So in summary about the intrauterine vacuum-induced systems, the JADA system is a promising device, tackling the leading cause of mortality and morbidity, especially in Georgia. The data to date are limited, if we are going to be honest, either because there was no control group, like in the 800 sample, which is a decent number, but the fact that it had no control group, always remember all bleeding stops at some point. And so it's a challenge. With the only comparative study to date, there is a challenge that, of selection bias, where the groups were not equivalent. And so, that keeps hanging at it. And then the studies have modest sample sizes, which often will prevent us from drawing firm conclusions. So, there's an opportunity to conduct a definitive randomized control trial where we are comparing the JADA system to something else, whether it's the Barry balloon or something else, to demonstrate its true role in the management of postpartum hemorrhage. And well, that's where we come in. So we propose the NOVIC trial, which is novel vacuum-induced hemorrhage control, a multi-center trial in Ghana. The first time I was trained in the JADA, I said, if this thing works as well as you say it works, I know a place. where it's going to really save lives. And so once it was FDA approved, we wrote a grant and we're lucky to get an R01 to conduct the first randomized controlled trial of the JADA system in the world. And so, Ghana is a low middle income country where the burden of postpartum hemorrhage and maternal mortality is huge. I still remember as an intern in Ghana, one of your jobs was to go to the blood bank with the cooler to get blood. And when you went there, you better brought the relatives of the patient to come donate blood. Otherwise, they write your name down. I still owe blood in Ghana. But if a device like this, if it proves to be as effective as the preliminary data sound, it will really be a game changer in the US and parts of the world. So our primary outcome, our primary aim is to evaluate effectiveness. Does this thing work as well as we think it does compared to the standard of care? And let me talk about standard of care for a little bit. This was a big debate in our minds. We did not want to send the Bagri balloon to Ghana as a comparator because they don't use the Bagri balloon. And so we thought the best comparator was to use the standard of care for postpartum hemorrhage management. I think it's ethically justifiable that we are doing a randomized trial in Ghana because it is not the first randomized trial. It's already FDA approved, and many of you are using it or will start using it in your hospitals. The third is that, as you will see in one of our aims, we are going to do cost effectiveness of the JADA system in that setting. And it's not just to say it's cost effective or it's not. It is to say, how much should you sell the device in Ghana for it to be cost effective? So it's going to be on its head. And I think it's no secret that the company is working on more affordable versions of the system as well. I had the pleasure of reviewing that. So I'm quite confident that we are checking those boxes where it is important that you consider those things before international studies. And then our one secondary aim is to look at safety. As you saw, maybe 1% of device-related adverse events, but we will confirm that. And then this was what I talked about earlier, doing a cost effectiveness, meaning how much should you sell the device for it to be cost effective in that setting. So this is the team. So this is the map of Ghana. So I come from the northern tip of Ghana, right here, Burkina Faso to the north, Cote d'Ivoire, Togo, and the Atlantic Ocean. And because, it's not working, but because the educational system gets better as you go down the coast, I literally went down to high school and eventually to medical school at the coast, and I left. I feel guilty every day, by the way. And so how I try to give back is to go home every day, every year, and to do research in Ghana. I have a bigger research team in Ghana than in the US, testing systems like this. And the only reason we're able to do that is that I have friends. So the gentleman in the jacket was my classmate in medical school, and he's now the chair of OBGyn at the University of Ghana. So that really helps. And I was in the same high school with the other gentleman. So we are able to conduct these studies in Ghana. So hopefully, in fact, the shipment of the devices, we had a call yesterday for the devices to leave Ghana from the US for organ, and we went already and trained the teams, everybody in the two hospitals, which combined deliver 18,000 babies a year. So I'm hopeful that we can do this quickly. But even if we found that the JADA system worked great compared to standard of care in Ghana, I think there will still be questions in the US about, well, what about in our high-resource setting? So we have a proposal at the NIH to conduct a multi-center trial of JADA versus Bagri in the US. So discussions are far in advance. Fingers crossed that we will get funding to be able to conduct that study. And it will be called a vital study, no pun intended, but I think it's vital that we demonstrate it. All right, so some take-home messages. Postpartum hemorrhage, I don't need to convince this group about its importance. Leading cause of mortality in Georgia, second leading cause in the US, and a leading cause of morbidity. I think mechanical devices are an important component of our tools. Otherwise, we move from medical therapy, and if mechanical devices don't work, we go to hysterectomy. And that is unfortunate on many grounds. In my role now, I have the unenviable task of sometimes, reviewing cases because, and asking the question, was hysterectomy an appropriate intervention? And it's really hard. On the one hand, this doctor just saved this patient's life, right? But we always want to ask, could we have saved the life without the hysterectomy? And it's not an easy question. And I think the more we have effective mechanical systems, the better we can save lives without having to resort to hysterectomy. And of these mechanical devices, the Bagri balloon is in routine use, and I think it has an important role. Frankly, this was introduced when we were residents or something, and it had a big impact on our practice, although the data we have today are all over the place as we reviewed. The JADA system is promising as a superior intervention to the Bagri balloon because its mechanism of action is more physiologic than the Bagri balloon, and the preliminary studies are very promising. However, it is important, as with most things, that we do what we need to do in order to get definitive data. I don't know about your hospitals, but the Bagri balloon is also in short supply. It's in short supply from the company, probably because it's much cheaper and they don't make profit from it. So especially with that reason in mind, while we do these studies, comparative studies, I think it's reasonable to have the Bagri balloon in your toolkit for the management of postpartum hemorrhage. Thank you.
Just use a 22 Foley bulb and put that in the uterus and hook the wall suction?
Yeah, no, I think it has as good a potential as any. But one feature I did not expand on the JADA system is that, so with just putting the Foley in, you have that hole, and there's always the potential that when you connect to suction, one, it could get clogged, right? And then also that endometrial tissue goes in there. So there's always the concern about injury. So that silicone hood, its job is to prevent direct contact of those pores in the loop with the uterine wall. But again, like the Swiss study suggested, it is possible that we could use some of the devices we have today in an ingenious way. Of course, I didn't mention all the improvised devices we all use, putting the sponge in there, sometimes with Hemobate and all of these things. They are all options. But just like the African studies with the condom suggested, we should test those new innovative interventions to make sure they do what we intended for it to do. And also ensure that we are not paying all the attention on that thing while we are not doing the basics you taught us about managing patients who are bleeding. Yes?
How tech students get compensated?
How?
The Caltech students, I hope they have been well compensated.
Oh, yes. So what then happened? Let me continue the story. So they did this thing, and it was so promising that they started a startup company called Alidia and went through the FDA process of getting it approved, and they sold it to Merck, the Organon, which is an offshoot of Merck. So I don't know, but I think they made a handsome penny.
Question for you, Doctor. Thank you for that great presentation. I'll say that I actually inserted a JADA last week on a patient, post C-section. Woman was a G22 P17 in 2023 in America. So I was all prepared for her to bleed on the table for the C-section because this was unfortunately her 17th baby, and she had had 10 VBACs since her last C-section. But long story short, she went to recovery room. Her operative blood loss was 650, but I had my Jada on the side table just in case. We got to the postpartum recovery room. She was doing fine until she wasn't. And then, of course, we initiated all the medical management options and finally did come and put the Jada in. And it was a 2 or 3 minute thing. But she did have a 2,200 cc blood loss. So I have a couple of questions. Number one, from a medical management standpoint, our usual path was Methodius, Cytotec, blah, blah, blah. Now it seems like TXA is the number one thing that you need to do first to start with postpartum hemorrhage from a medical management standpoint. And so I guess my question is, do you agree with that? And secondarily, at what point in the postpartum hemorrhage process do you decide that now I need to go to a mechanical device?
So those are both excellent questions. So first I will say, in terms of the Intrauteronics, every institution has to develop an algorithm for the management of postpartum hemorrhage. So it's standardized, it's second nature, and unless there are contraindications, you move from one to the other and to the other. I see TXA more as a prophylactic measure because it prevents fibrinolysis and helps the blood clots to stick, while Intrauteronics actually work on the uterus for it to contract. So I will consider it as adjunct while I follow the path of Intrauteronics. Now, in terms of when you will move on, that's the $1 million question. One thing I can say for sure is that we often wait too long. I think, especially in training programs and so on, we wait too long. And so by the time, we are beginning other interventions, we've already lost a lot of blood, DIC may start setting in, and therefore the bleeding just self-perpetuates itself. So that's one angle. The other angle is also proponents who are saying you should even just start the Jada as a first-line therapy. As with most things, I think the truth is somewhere in the middle. So in the US trial, where we are comparing it to Barry, we are defining failed medical therapy as the use of another Intrautonic in addition to oxytocin with continued bleeding. That is our way to try and balance not starting it too soon as first line in everybody because it's expensive, right? Like it's $800, $1,000. If it works, I bet it will be cost effective because it prevents transfusion and all of that. But it's a device. We are putting something inside the uterus, and we don't want to do that willy-nilly. So I think that I think every institution has to have a protocol where you define that. But I think whatever you do, find a middle ground between not waiting too long and then things don't work as well and patients already have morbidity, and also not making that the first thing that you do.
Well, I actually got called when she was at 1800 cc.
Yep. 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 No, absolutely. So that observation, that 1 hour after delivery, as we know, is crucial. And unfortunately, a patient that's post-op and maybe covered, if the nurse is not checking, they will just get the surprise when they open up those drapes. That's why, people are, you have to look at the vital signs, right? They may start being, tachycardic before they're hypotensive. But, fortunately, we take care of generally younger patients and who can take a lot of abuse before they start telling us they are not doing well. So there are sensors being developed, for example, that may be able to warn us about hypovolemia even before we see evidence of the blood or vital signs begin to change. But that's an excellent question.
Infertility problem? What is the long-term effect of postpartum hemorrhage in the patient? Menorrhagia symptoms or infertility? Because I get a lot of patients, they had the first baby and after that they cannot get pregnant again. And adenomyosis, endometriosis, and all this stuff.
Yeah, so the question is about the long-term effects of postpartum hemorrhage, and I will say, and its management on patients. So one of the things we talked about iron yesterday, but that patient who has lost 3 liters of blood. Even if you transfuse them, their iron stores have taken a hit, and it will take a while for them to replenish that. So we need to be mindful and make sure they are well repleted. But I also think some of the things we do in the management, it may be a curettage, which results in Asherman's that could worsen their fertility. There could be infection that occurs just because of the hemorrhage or whatever we do to them, and that could result in tubal causes of infertility as well. One of the things somebody pointed out at one of these talks I gave is, have we looked at the long-term effects of intrauterine devices on fertility and other things? And that's a good question we will work on looking at as a follow-up to patients who are enrolled in these trials.
It's just one of the reluctance, I think, as physicians is for us to grab a device that costs $1,000. And I don't think we have a good recognition of the expense of blood transfusion. So will you just comment on the monetary assignment of a cost of a blood transfusion?
Yeah. No, that's an excellent question. So, as a physician, I want to do the thing that's best for my patient. But as we all know, the economics of healthcare is becoming even more and more important, because if your hospital ends up not affording to stock the device, you don't even get to use it at all. So, I don't have numbers for actual what a blood transfusion costs, but it is not cheap to give one blood transfusion. And it's not just even the blood transfusion, right? Blood transfusion is safe now, but there are all kinds of consequences that can happen, including trolley and all of these things, infection, rarely. I do think that if a device like the JADA system is 90-something% effective, reduces the risk of massive transfusion by that amount that a comparative study showed, reduces the blood loss by that amount, it will likely be cost effective. But that's why we are doing this as a formal economic analysis as well. But we should demonstrate that. We should, I know some people are already probably working on an economic analysis of, if it's as effective as the current data suggests, you take a cohort of patients, you use it, you don't use it, what are the outcomes, and what is the cost associated with that? But it's an excellent question. My guess is that it will be cost effective. But let me add this. Cost effectiveness is a tricky thing. So cost effectiveness is usually analyzed from a societal perspective. So we'll say in the US, anything that costs $50,000 to $100,000 per quality adjusted life years is considered cost effective. But there's cost effectiveness at the hospital level, where you are dealing with reimbursement and everything, and cost effectiveness at the provider and the patient level. And so I wanted to mention that there are those complexities associated with that.